Fortunately, I'm really honored to be given the opportunity to talk today and tomorrow. And today, the focus was going to be on thinking about pathophysiology and positive diagnosis. And then I was going to leave for tomorrow thoughts about diagnostic explanation, and particularly around service development. So these are the things that I was hoping to sort of talk to you about today. And starting off with a question which has sort of been intriguing me for as long as I've thought about these sorts of problems, which is what thing has gone wrong in the brain? And obviously that's a very big question because there's lots of things that probably go wrong. But a slightly easier question might be, what's the system that's gone wrong that is closest to producing the actual symptoms? So that's what I mean by a proximal mechanism for symptoms. And then trying to deal with an issue which is still a very live one, really, which is what is it that what's the evidence that FND is not just feigning, because lots of people think it is, and then thinking about what all that means for making a diagnosis and starting the process of a formulation. So let's thinking about this bit first of all. So human beings are definitely more than stimulus response organisms. So even if you take a really obvious thing like shutting your hand in a door, the conscious experience of that is only mediated through the brain. So without a brain in the way, there's no conscious experience. So, and we recognize already that phenomena, so simple physical phenomena like injuries, are experienced very differently in different circumstances. So we're used to this idea that this processing in the brain is a dynamic process. It's not something which is fixed. And so that leads to thinking about what sources of data the brain has, or we have, in this situation. So there's two sources of data. There's the bit that we think about most of all, which is feedback. So that's information coming in from the sense organs up to the brain. So that's sometimes called bottom-up sensory data. But there's a very important aspect as well, maybe even more important, which is a top-down process, which is about predictions. It's about expectations or predictions about what data we're expecting to experience. And so that's why I put up this picture of people playing tennis. So the person who's about to hit the ball has quite a lot of bottom-up sensory data from his visual system about where that ball is going to be, and that's acting to help guide his movement. But the people on the other side of the net are not just standing still, waiting for sensory feedback. They're moving, and they're moving in a predictive fashion. So they're already predicting where the ball is going to go. And the person on the other side of the net is doing an even more meta calculation of predicting where the ball's going to go and then where these people are going to hit it. So this predictive mode of operation is extremely important in the nervous system. It's a very efficient way to act and to sense, and it's something where you don't have to wait for relatively slow sensory feedback to be able to guide your action and so on. And I think it's important to recognize that this is a dynamic system, and aspects of attention are important as a sort of volume knob in a very simplistic way that dial up or down the power of the attended source of data. So there might be situations where the brain is particularly attending to bottom-up data or particularly attending to predictions. So that helps us explain these sorts of phenomena. So I would expect that this man playing rugby is probably not in pain. And I don't think that's because he's an incredibly tough rugby player. I'm sure that if he got this injury when he was just sitting on the sofa watching television, it would be really painful. But it's not painful because of this dynamic system. His attention is diverted. The bottom-up sensory data that's telling him, that should be telling him that he's in pain, is not getting through, because it's being drowned out, it's being suppressed by this sort of top-down predictions and also his focus of attention. So the idea here is that really what we're doing most of the time in terms of action and sense and thought is really an automatic process based on predictions. So for example, I would be prepared to bet a lot of money that none of these people walking across the street are worrying or thinking about the angle of dorsiflexion of their right foot, even though that's an essential piece of information in order to walk and stand upright. So that's something which is happening outside of conscious control in this automatic system. So just thinking about these beliefs and expectations a bit and trying to kind of put some meat on that. So if you didn't know much about science or medicine, and somebody who looked a bit sciencey came up to you in a shopping center and said, we've got this amazing anesthetic cream, we've spent billions of dollars developing it, and what we're going to do is a little experiment. We're going to check your pain sensation, and then we're going to put on our amazing cream, which is going to numb your skin, and then we're going to check your pain sensation afterwards. And we think it's going to be much less because our cream is great and it comes in this calming blue bottle. If, unbeknownst to you, so you didn't know, but they actually just put on some moisturizer, what do you think would happen? Well, we know what would happen because people have done this experiment in lots of different ways. And what we know is that people experience less pain. And we think about that as a psychological phenomenon, which I suppose it is. It's a change in belief, isn't it? But we don't often think about how that's implemented. So how is that working in the nervous system? How is it possible to feel less pain just because you believe that some anesthetic cream has been put on your hand? So this is an experiment which sort of gets into that a little bit. So this is an experiment where people are wearing a pair of headphones and they're given an auditory cue. So there's a particular sound which warns them that they're about to receive a mildly painful stimulus, so a low pain stimulus. And then there's another cue which warns them that they're about to receive a more intense, a high pain stimulus. And then after they get the stimulus, they have to rate how painful it was, but also they're having evoked potentials recorded using MEG. And in a broad sense, the amplitude of these evoked potentials are correlated with the intensity of the stimulation. So as is normal in these experiments, people are lied to. So some of the time, people get a cue that says this is going to be a low pain stimulus, but actually it's a high pain stimulus and vice versa. So what happens in the behavioral ratings is what you would expect. So when people are told this is not going to be that painful, and actually it's a high pain stimulus, they feel it is less painful and vice versa. But the more interesting thing is what happens in the evoked responses, which is in that situation. So people are told this is going to be a low pain stimulus, but actually it's a high pain stimulus. The amplitude of the pain evoked responses are reduced and vice versa. So when you're told this is going to be a high pain stimulus, but actually it's a low pain stimulus, the amplitude is increased. So what you believe changes basic low-level sensory processing through this dynamic system. And that's why it feels less painful. So just to give you another example of that, here's a fairly famous illusion called the hollow mask illusion. So I've deliberately chosen this very old video, so you can't accuse me of using some computer graphics. So this is a hollow mask of Charlie Chaplin. And I hope you can see the video okay, but on my screen, as it comes round, I can see now that it's hollow. And then for most people, not everyone, a weird thing happens and the face pops out towards you. And then again, on my screen, I can now see just about now, it's definitely a hollow mask. So you can play this video 1,000 times. You know it's a hollow mask, but you can't see it. And so this is something, again, about the power of predictions. So because we know that noses come out of faces, when you're presented with a slightly ambiguous stimulus, that's what your brain sees. That's your conscious experience, even though you know it to be untrue. So these predictions and this predictive mode of working is extremely important in our sensory and motor and cognitive experience. And just one other aspect of this predictive system before moving on is that this is also seems to be important in our sense of agency, so our ownership, our sense of being in control of our own bodies. So this is an experiment which is called force matching. And in this experiment, what you have to do is you're given a force of a particular magnitude on your finger, and you have to match it either by pressing down on your finger or by operating a complicated robot device. So this experiment was developed based on this finding that people can't tickle themselves. So if you try to tickle yourself, it's not very ticklish. If somebody else tickles you, then it is. So that's an interesting phenomenon because it's the same stimulus, but it seems to alter in your sensory experience, depending on whether it's you or it's someone else. And so in this experiment, when you're pressing down on yourself, people are not very accurate. So even though it's quite a simple thing to do, they press much harder than they need to. But when they're operating this robot device, they're much more accurate. And so this has been used to try and explain this phenomenon, that when movement comes from yourself, you're already predicting the sensory consequences of it. And so somehow the feeling is turned down in a way. So in order to feel the same, you have to press much harder. So interestingly, this is abnormal in people with schizophrenia who have delusions of control, where they are hyper accurate. So they are better than healthy people. And we'll come back to this experiment, but it's just to show that these predictive systems are also important in self-agency. So what we talked about so far is that our experience, our conscious experiences of our bodies and the world is mediated by this dynamic system, which is fundamentally predictive. And things that we think about as voluntary are, well, they have voluntary components, but they're fundamentally automatic processes, which we sort of direct by a spotlight of attention. And that it's a very unusual situation for that spotlight of attention to be onto the body, to be thinking about the mechanics of moving, the mechanics of feeling, the mechanics of thinking. And that also systems exist, so similar systems exist, which allow us to experience ownership and control, so that give us a sense of agency over our bodies. So the very basic point when it comes to functional neurological disorder is that if systems like this exist, then they must be able to go wrong. And it will therefore be really extraordinary, to be honest, if functional symptoms didn't exist. And if you think about these systems going wrong, these systems around attentional focus, loss of automaticity, abnormal predictive states, these are things which you would expect to cause significant physical, movement, sensory, cognitive symptoms, which would have the characteristics of functional symptoms. So this is an old paper now, and this was trying to put these ideas together in a framework, and in the same sort of framework which is used commonly within psychiatry, in particular around computational psychiatry, to explain things like delusions and hallucinations in people with schizophrenia. And this is the idea that if you imagine that the top left-hand picture is a probability map of sensation in your left hand. So there's sensation that might be strongly predicted, indicated by that red peak. So hopefully that's normal sensation. And there will be things that were strongly not predicted, like severe pain. But then maybe something happens to you. Maybe you fall over and you hurt your hand and it's painful. But that doesn't just happen just because. Maybe that happens in the context of an accident with significant psychological arousal, with panic even. Maybe you're taken to hospital by ambulance. Maybe a doctor says to you that your arm might be broken. Maybe you have particular illness beliefs. Maybe you have particular background psychological factors, from anxiety to post-traumatic stress disorder to depression. And all of those could be different in different people. But what's happening there is this prediction is being driven to somewhere else. So now something completely different is being predicted strongly. And that could be severe pain. It could be absence of sensation. And then all you really need to do for that to manifest is for attention to be diverted onto the body. So if you check in on your body, how is my hand feeling? That dials up this prediction. It turns up the volume of that prediction, meaning that you experience what you predict, like severe pain or loss of sensation. And then when your attention is diverted away, that disappears, but you're not aware of that. So that's happening without agency. It's not you said, I want my hand to hurt. All you've done is turn attention onto the body. And it's that that's driven the onset of symptoms. So let's just move from that discussion into thinking about, well, maybe if we have the beginnings of an idea about there could be a system in the brain that's responsible for these sorts of symptoms that could make sense, that's not a system which is damaged by a disease process like a lesion, for example, but could malfunction, could be triggered to malfunction in particular ways. How do we deal with this issue that's been present throughout, I think, the story of functional symptoms, which is, what's to say that they're really real? Why aren't they just pretend? And I can understand why that's the case, because They are modulated by attention, like voluntary movement is. So when attention is distracted, things often get a bit better. When attention is put onto them, they're worse. You can show that the basic mechanics of the system is okay. Investigations are normal. So why isn't this just pretend? So in order to answer this question, I was lucky enough to collaborate with John Stone and another colleague, Mahinda Yogaraj, on this paper, which is recently published. So if you want to read all about this, this is in Nature Reviews of Neurology. But I'm just going to take you through just some key bits of evidence, and there's lots more in this paper. So first of all, this is a really consistent thing over time. So here's some pictures from 19th century France of a dragging gait in two people. Here's somebody who's coming back from the First World War, so in 1916, with a dragging gait. Here's a patient of mine a couple of years ago with a dragging gait. So the phenomenology of these things has been very similar over time. So it seems a bit unusual, that, doesn't it? That everybody should be doing the same thing. And you can see it across different symptoms, like with fixed dystonia, with functional dystonia, with appearances of seizures, like the famous arc de cercle appearance. Not to say that that's a particularly common phenomenon, but it's there historically and currently. So that's interesting, isn't it? It's seeming like a fairly normal condition. And then there's also treatment response as well. So why is it that people who are pretending would improve with treatment, and not just improve with any old treatment, but would improve with treatment which is relevant to symptoms? So for example, in this paper on the left, this is looking at specialized physiotherapy versus not nothing, but good quality, non-specialized neurophysiotherapy. So everybody received physiotherapy, but this intervention group had physiotherapy that was more tailored towards functional neurological disorder in terms of the models we think about what might be going wrong. And about 70% of people respond, get a good outcome in the intervention group versus 20% in the control group. Here's a placebo-controlled trial of sertraline in people with functional seizures, non-epileptic seizures. And again, you see a positive response in people who are in the sertraline group. So, and there's actually a positive response in the placebo group too. So why are these people improving if they're just pretending? And there's also experimental evidence too. So there have been a number of studies done. This is a very early one from 2000, but there have been a number of studies done, mainly functional imaging studies, looking at people with functional symptoms compared to people who are healthy and are told to pretend. And in these studies, generally speaking, the pattern of brain responses is very different. So they are significantly different one from the other. So they don't look like, so the people with functional symptoms don't look like people who are feigning. I appreciate that there are problems with these experiments in that you could argue that a healthy person told to pretend is not the same as somebody who is malingering, but it's still an interesting phenomenon. And then there are studies which result in sort of passive things. So when the participants not asked to do anything. So on the left, here's a study where people are observing movement and they're looking at patterns of brain activation there. So when we observe movement, typically through the mirror neuron system, there's activation of the similar sort of analogous part of the brain. And in patients, but not controls, and only in their affected limb. So when they see somebody, they watch somebody moving the limb which relates to their affected limb, the amount of brain activation is significantly less than when they're observing somebody moving with their what's analogous to their healthy limb. So that's just something which is happening when they're just watching the person, not being asked to do anything. And here's another study where people with functional motor and sensory loss had their arm with the sensory impairment vibrated and looking at brain responses. And you can see that when these people were looked at time 1, there's a reduction in response. After they have treatment and after the patients have improved, that response improves to normal again. So this is just passive, this is vibration. They're not being asked to do anything. And this is one of my favorite studies in this field by Mark Hallett and Valerie Voon, where it's a within subject study. So here's a study where people had functional tremor, but there were also times where they didn't have that tremor and they were asked to pretend to have tremor. And if you compare those two situations, so a situation where the person's having tremor, which they are voluntarily doing, and having tremor that they experience is involuntary, there are differences between them in the temporoparietal junction, a very important area when it comes to a sense of agency. And there are things which you would think are really difficult to feign. So coming back to that force matching experiment, I was involved in a study looking at that same thing in people with functional movement disorders. And they get a similar pattern to what you see in people with schizophrenia, in that they are hyper accurate. So they are more accurate than healthy controls in this task where they're pressing down on themselves. And it seems odd, really, in the extreme, that that could be explained by feigning. So I think there is a more complicated issue, which is that if we're saying that what's going wrong in people with functional neurological disorder at this sort of very symptom-related level is a malfunction in a system which is important in embodiment, in our sort of conscious interface with our bodies, then it is logical then that other things around that would also be expected, including, in particular, emotions, including the relevance of psychopathology, including the relevance of your social environment and so on. So that it makes sense that those things would be particularly important in people with FND. And so it makes sense that we would see the things that we do see, where those sorts of diagnoses, early life experiences, current experiences, social situation, all the rest of it are really important in driving symptoms and are relevant risk factors for the development of functional neurological symptoms. And that brings me to another point, which is that the things I think that doctors are often sort of picking up and assuming are part of malingering are things which are around patterns of behavior and interaction, particularly with health services. So this thing of doctor shopping, going around to more and more and more doctors, having difficult encounters, turning up at the emergency department, doing things which feel like they're displays of disability. But instead of thinking of those as malingering, another interpretation is that those make sense. So they're an expected consequence of the interaction of the pathophysiology of FND and the broad comorbidities that are there, and our health systems, our health and society attitudes and beliefs, etc. So putting it round another way, if people have this vulnerability and this impairment in psychosomatic integrity, then that's going to be strongly magnified and revealed by others, particularly in the way in which our health services are currently organized. So just to give you an example of what I mean by that in real life, here's a couple of excerpts from interviews with patients with functional symptoms from Glenn Nielsen, who's a fabulous neurophysiotherapist that I work with. So here's a patient talking about going to her primary care doctor. So I go to the doctors and I say to him, if I fall down, I can't get back up. There's no strength on my left side. And I could see the doctor was vague. He was looking at me so vague. And I think all of us know what that looks like. So I thought, right, in his surgery, I put myself on the floor. I thought, okay, you watch me. I can't get up. So he saw me struggle. I had to go against his chair to pick myself up. Then my whole body went down. I fell. He did apologize because it allowed me to fall down, which was the only way of getting him to understand what I was saying. So this is from this discussion, it feels like a significant degree of voluntariness there. There's an interaction, isn't there? But it's about communication. It doesn't mean that the whole problem is of malingering. This is a problem with being able to communicate a really difficult and disabling diagnosis. So just in the last 10 minutes or so, just to think about what we've talked about, and I appreciate we've covered quite a large area. What does that mean? What does it imply for diagnosis? And then starting to get into the idea of formulation, which I'll look at a little bit more tomorrow. So one thing is it starts to make some sense of the onset, the triggering of functional symptoms. So when you look at people with functional symptoms, particularly functional movement disorders, it's really common for people to have a health problem at the onset. So these health problems can be all kinds of things, from injuries and accidents to medication responses, operations, migraine, flu, whatever it is. But commonly in this study, 80% of people, they were experiencing a problem in their body. So they were experiencing symptoms which had a clear cause. It wasn't that these were the trigger was a functional symptom. These had a clear cause, but they were all things that you would expect just to get better. But instead of getting better, they triggered the onset of functional symptoms. So that's always made a lot of sense to me, because in this predictive model we're talking about, you get new sensory data in. That's the kind of thing that can change these top high-level predictions about what we're expecting to experience in our bodies. And obviously that's affected by the psychological component of triggering events. So most people in these studies around physical precipitating events, they report a lot of symptoms that would usually be associated with panic responses, but they typically don't label them as panic. So they don't say, and I felt panicked and anxious. They often just report the physical symptoms instead. So I think that helps make sense of onset. And if people have those sorts of physical precipitating events, sort of putting them into the formulation is really helpful. So this is a patient talking about that, and hopefully you'll be able to hear the video. There's also subtitles. So this lady is talking about her experience at the onset of symptoms. So she went in to have an operation on her hip, a hip replacement. When she was in the recovery room, her breathing rate was low. So they thought they had over-sedated her. So they gave her naloxone to reverse her sedation. And what she's going to talk about is the moment that they gave her the naloxone.
What's the very first thing you remember happening?
What happened was the drug, had an immediate effect. Immediate effect was heat. It was looking at my body, and it felt right round by my heart. I had an incredible chemical taste in my mouth and in my nose. It enveloped me, this smell and taste. And I actually, my husband had a heart attack, and they've given you magnesium. But they give you magnesium or whatever. And I actually thought I was having a heart attack. And that was. And I said that warmth just to wake up my body. And I remembered it. But and then I was aware of I was shaking. And,
your whole body was shaking.
It just sort of went, yes. And that's how it all began. And it stayed with me. I heard the one doctor say to another doctor, "Have you ever seen this reaction before?" And the doctor said no. They asked another doctor and a nurse, and I felt I was surrounded by people who didn't actually know what to do.
Yeah. And
the only person I could trust was my husband.
Yeah.
But I heard them say, "Oh, she's having a panic attack." And, I called her, "I'm not having a bloody panic attack." I was really cross, actually. But I did think I was going to die at one time, because I just had the hip done and it was shaking away. Yeah. And I've had problems ever since with this hip as well. So the whole experience.
So that's such a rich event, isn't it? So she's recalling this 4 or 5 years later, and it's still right at the center of her head. So she gets the naloxone, she gets this weird experience, which I'm sure is about the naloxone reversal. And then in that moment, she remembers that when her husband had a heart attack a few years before, they'd given him magnesium and he reported this sort of strange sensation. So she immediately thinks, I'm having a heart attack. Then she feels her whole body shaking. And then she hears people talking. One doctor says to the other, "Have you ever heard this before?" "No, I've never heard it before." And she feels like she's surrounded by people who don't know what they're doing. And then somebody calls out, "Oh, she's having a panic attack," which completely invalidates her experience. Doesn't feel like she's having a panic attack. She feels like she's going to die, which of course lots of people do when they're having a panic attack. But that's not her experience. So for her, a significant part of trying to help her, and at this point she was taking a legal case against the hospital where she'd had this procedure done because she believed that her brain had been damaged by naloxone. She was on online groups about naloxone brain damage. So the first part was explained to her that yes, the naloxone did cause that initial weird feeling, but then it triggered another process, which is a functional neurological disorder, and you can understand how that will happen. So and it can also help make sense a bit of the background risk factors. So we know that stressful life events, that maltreatment in childhood, these are all things that are commoner in people with functional neurological disorder than they are in people who don't have FND. But they're not universal. But you can understand how those sorts of experiences might create vulnerability, and that vulnerability might be different in different people. So what it's trying to do is bring together this sort of wider way of thinking about functional neurological disorder. So I've started with what I've called a proximal mechanism for symptoms. So that's the stuff that's right next to the symptoms. But then there's, when we look at the growing understanding of pathophysiology of functional neurological disorder, we can see widespread changes in brain networks, as you would expect in a complex disorder, which spans physical symptoms, but also significant cognitive and emotional changes. So what does that mean from a diagnosis point of view? So I think one of the biggest changes has been moving from this idea of an exclusionary diagnosis, where you just do loads of tests, and if they're all normal, it has to be FND, through to a positive diagnosis. And this is the way that I would usually think about functional symptoms, that they're a problem with the person experiencing abnormal function in a system that you can demonstrate to be capable of normal function. So here's what I mean by that. So I'm just asking this man to lift up his leg. He can't do that. Now I'm asking him to push down against my hand, so to test hip extension, and he's got 0 power of hip extension, so his whole leg's paralyzed. Now all I'm going to do is to trigger movement in that leg by getting him to flex at the other hip. So when you flex at one hip, the other one automatically pushes down. And now he's doing that, and his leg is pushing down. So that's Hoover's sign. So that's a very sensitive and specific test for functional weakness. But that idea, this basic idea of experiencing abnormal function in the system you can demonstrate to be capable of normal function, underlies diagnosis of really all functional disorders. And there's 2 main diagnostic pillars, if you like. So there's this idea of inconsistency. So the disorder's variable over time, and its distribution, the symptoms and signs in specific features like tremor frequency. And it's strongly influenced by factors, external and internal factors, that's distractibility. And also that it breaks some basic rules about anatomy and physiology. So I think this is something that you can often pick up in what I call the casual examination. So this lady's talking, and as she's talking, like most people, she has normal saccadic eye movement. So her eyes are moving around back and forth. So this is a casual examination of her eye movements, which look normal. So now she's having her eye movements formally examined. And now she's having enormous trouble. You can't see the person's hand, but there she's following the examiner's hand back and forth. And now it's extremely difficult. Okay, and so that's an influence of attention. So that's around this variability. And here you can see a person with tremor, with functional tremor. So in a second, he's going to do a cognitive task, which is not a great distractor, to be honest. But in a moment, he's going to do a better distracting task, which is following an examiner's tapping at a different frequency. The tremor's completely changed its frequency, and now it's started to entrain a bit. So sometimes things are a bit difficult. So this man has jerks of his abdomen. He has myoclonic jerks. It's a bit difficult to know what that is. I could tell by the pattern that that's more likely to be a functional disorder, but it's quite hard to know for sure. Jerks, which are intermittent, a bit more difficult to distract, but you can do tests, like you can look for pre-movement potentials. So here, if you're connected up to an EEG and you make a movement when you feel like it, there's a slow rising negative potential in the EEG. So this is movement, and then going back in time, you can see the change in the EEG. And this is what you see in people with functional myoclonus. And then there's situations like this, where this lady is complaining of poor balance and has this kind of falling. But just there, she stood on a narrow base and her whole center of gravity shifted forward and back again without her falling. So that demonstrates good balance. So it's again this mismatch between what you're seeing from a basic neurological point of view in terms of normal wiring, if you like, and then but then significant dysfunction on the top of that. So I've spoken a lot today about the sort of neurology and a bit about neurobiology and so on, but I really don't want to give you the impression that that's what I think FND is. So having a sort of simple explanation about FND never works very well. And just to illustrate that, if I asked you what this was, you might say it's a collection of ones and zeros, and maybe this is some color, some pixels. You might see a line there. You might see it's a human form, and then you can see it's the Donald. So my point here is that saying this picture is a set of ones and zeros or an ex-president of the United States is not true in isolation. It's all of these things and everything in between. And so there's a real tendency amongst health professionals, scientists, and society in general to want to reduce things to one thing or another, and particularly to a sort of neuro-reductionism or a psycho-reduction or a socio-reductionism. And that doesn't work. Thinking at a neurobiological level, like we've just been doing a bit now, doesn't mean that that's the only level. It doesn't mean that it's necessarily the most important level, the most relevant level, the most real. It's important and relevant and real, but it's context specific. And when it comes to helping people, we need to think in this multi-dimensional way. So I hope that was interesting as an introduction to some of these ideas. And I look forward later on today to maybe taking some questions. Thanks very much.